بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I will introduce myself to who don't know me. I'm Dr. Ala Salman. I'm from Syria, Damascus. This is my city. This is from my home window in my house. I study dentistry in Damascus University, and I study orthodontist in Al-Ba'ath University. I worked 2 years, about 3 years in Al-Tabib Dental Center. I cannot find any lecture, but I got a brochure. We always had this offer. And I'm now working with the Gnp Hospital for 5 years approximately. Our journey in this lecture begins with a problem. When the patient comes to our clinic, he comes always with a problem. He has pain, he has cosmetic problem, sometimes psychological problem, but he always comes not to say hi. Even if he wants to say hi, he has a problem with the hi. So how we can deal with this problem? We first investigate, we do our routine oral examination, we do our routine records, for example, X-ray, and we have a lot of situations after that. We have bad dentist. What I mean about that bad dentist, a bad dentist has lack of information or lack of experience, and he cannot solve the patient problem. And it's all right. We always, once a time, be a bad dentist. We always, even now, in front of some difficult cases, we are a bad dentist. We are not perfect, but there's a worst dentist. The worst dentist, he knows the problem exactly where is it, but he don't want to treat the patient for some reason or another, and he said, okay, your problem, extract the wisdom teeth. The patient said, my problem is the upper teeth, doctor. No, I know better, I will transfer you and recommended very good surgeon for you. And next patient. I think he has lack of conscious and medical ethics, but maybe I'm wrong. We have the worst dentist. He has the knowledge, he has the manners, he do further examination, he is super dentist, his skills perfect, and he solves the patient problem. So maybe you call him the normal dentist, everyday dentist, and this leads us to the question, who is the good dentist? In my opinion, and not only my opinion, nowadays in the Western, in America, in the United States, or in Europe, the good dentist not only solves the patient problem. He look at the whole picture. He look at not only the specific reason that make the patient come to his clinic, but also do a comprehensive diagnosis for this patient, good possible treatment options, not as the patient said, I want to extract, okay, I will extract for you, with cooperation of his teamwork, if he works in a clinic, or with his colleagues in other centers, if he is alone. And finally, he communicates and educates the patient about this problem and in general, and about the best plan for him and the options that he can do. So, starting from this point and this introduction, I think about this lecture with this title, Guidelines for General Practitioner or any other specialist for examining and referring orthodontic patients. Talking about the diagnosis, it's not an easy word. We have Dr. William Prophet, he is king of diagnosis. He has this book, Contemporary Orthodontic, now the 5th edition. It's 160 pages out of 700 of his book about the diagnosis. So I cannot in 30 minutes, 40 minutes, and even in 2 days maybe cover all the diagnosis of orthodontic. What I'm giving now is only tips and general addresses about things maybe help the general practitioner in the clinic taking orthodontic diagnosis when we look at his patient. First of all, our modern orthodontic know more about the teeth and the bite. It's about the face. Our dentistry in general is about the face of the patient. So a lot of doctors, when the patient comes to the clinic, they are busy filling the file of the previous patient on their computer or whatever. They don't even look at the patient, and this is absolutely wrong, because we need to look at the patient, see his face, not the beauty of his face, the balance of his face, the profile. As an orthodontic part of view, I think the lips very important. Incompetent lips, it's a very strong evidence that there is something wrong in the mouth. Of course, also, we must look at him at his smile. Smile now, maybe after 2-3 years, there is a new specialist in orthodontics, Smiledontics, for example, because a lot of courses, a lot of conference, a lot of books about smile and smile design. There are some things we can look about smile, like smile arc, and if there is tilted in the occlusion plan, about the midline of his smile, about the width of his smile. If it's narrow, there is a buccal corridor, black, a triangle. And also teeth and gum exposure. Sometimes there is gummy smile, and sometimes vis-a-vis there is the lip cover the teeth. So smile very important. Also talking, when we are talking to the patient, we must look at the anterior teeth, because while talking, the anterior teeth is the one it exposed. We call it in orthodontic the social six, the six anteriors exposed in talking, not with smiling. So both upper and lower anterior teeth is important in smiling and talking. After we look at his face, we sit on the chair. We start with the teeth. First, we count the teeth, because there is missing teeth, impacted teeth. A lot of cases, there is missing tooth, but the contact point is perfect, and nobody noticed there is missing tooth, by the way. And then we look at the crowding, we look at the spaces of the teeth. The bite, of course, we look at the 3D, 3 dimensions of the bite. The first dimension, anterior, posterior, the famous classification of occlusion, the class 1, class 2, class 3, I think all of you are familiar with. Most of the cases, of course, it's class 1, and come number 2, class 2, and the class 3 is the less seen. According to this study, maybe it's not here in Saudi Arabia. In the vertical dimension, we see if the bite is deep bite or open bite, and in the transverse, we see if there is any cross bites. Always, also after we finish face, teeth, bite, we look at some function. For example, the swallow of the patient and the breath of the patient. We ask him if he feels any pain in his temporomandibular joint. And now a lot of studies ask the patient about sleep and sleep apnea, and they discovered that the problems in mouth cause a lot of problems with sleep, even sometimes death. They do now a lot of surgeries, not for beauty, not for the bite, but for the sleep and the breath airways. After we taking these points in consideration, we think about this patient. If he need, if his problem is complex, complicated, need comprehensive orthodontic treatment, or just we can use the orthodontist to support our solutions. Also, we mustn't be so ideal. Sometimes there is patient, there is a problem in ortho-related problem, but no need to take care of it if the patient don't ask for it. It's a small problem. I'm trying to give some examples for adjunctive orthodontic treatment, the cooperation between the orthodontist and other specialists. First, about the pedodontics. Class 3 pedodontics is very important and very emergency case in orthodontics. Even if one tooth crossbite, we need to treat it as fast as possible and as early as possible. We start at 6 years old. Many patients think the orthodontics start after 12, and many dentists also, but no, skeletal problems, especially class 3, as early as possible. Class 2 vertical problems, transverse problems, we can start between 9 and 12 after the anterior erupted and the first 2 permanent molars. Also, some kids now have a psychological or social problem because of their teeth. We don't, in the past, put braces for children, but nowadays I think it's changed, and we sometimes put, we call it 2x4, 4 braces and 4 anteriors and 2 on the molars to correct some problems only for the psychological and social problem for the teeth. About the cooperation between us and the surgeons, of course, first of all, we have the impacted teeth. All the patients with impacted teeth go to the surgery first, don't come to us. And we need to sit together and think about this case and make further examination, combine maybe, to determine if this patient, better solution for him to extract or to orthodontically put the tooth in its place. In implant, of course, we can make space for implant, or we can make better place for implants by uprightening some teeth. And nowadays, in the last conferences I attend, they tend to put the implant first, and then depends on it in the anchorage and then the treatment of orthodontic, and then put the final crown at the end. So the surgeon and orthodontist work very much more closer and together in planning these cases. And of course, the third molars, the most questionable question I asked. My friends, the third molars have nothing to do with orthodontics. There is no study support that the third molar make any crowding in the anterior. So please don't tell your patient this anymore. It's a wrong culture we need to change. We extract the third molars if there is localized problem. Sometimes we extract the second molars and put the third in its place, and we can think always about this solution if the second molar is bad and discuss about it. What about periodontitis and orthodontist? Of course, the orthodontic treatment improve perio environment. If there is crowding teeth, it's very hard for the patient to take care of his teeth, and so always we can advise the patient to make them more aligned, and it will be held. Deep bites, sometimes I see very deep bites, the anterior teeth, the lower anterior teeth, bite on the gingiva of the upper anterior teeth and make severe periodontitis problem. Also, we can include these teeth and solve this problem together. Sometimes traumatic occlusion on one tooth, make it move or make it recession of the gingiva. Also, we can solve it with orthodontic treatment. And the gum smile, of course, the patient think that the gum is, they go to the gum doctor, but also orthodontic doctor can do a big part of including the upper teeth and helping solve this problem for the patient. About the orthodontics, we have bridges, uprightening like the implant, of course, or create more space, and most of all, rarely happens intrusion of the upper opposite tooth. Rarely happens, nobody transfer patient like this to me, I mean. But it's very useful. I think any patient you told him I need to remove the enamel or make RCT for the upper tooth, or you need to put 2 mini screws and do orthodontic treatment for 6 months, he will choose the other solution, I think. Also for single, we can single crown, we can do crown lengthening. I tried it once, it was not successful, but I think we can do it, and it will be successful for crown lengthening to do the crown with the help of orthodontic treatment. Aesthetics, I think any doctor can give good smile for the patient without help of me. He can remove the enamel, do RCT, whatever, and then give good result. But orthodontic give us the best result because it protects the teeth from over-preparation. It manages the spaces between the teeth. Sometimes we need more space to make the teeth wider and the smile more balanced. And sometimes there is spaces and we need to close them a little bit by orthodontics and then put our veneers. So orthodontic here, it's not a comprehensive, he will not solve the patient problem. It will be less than 1 year, but give much more better results. For GPs and other specialists, please, before starting any restorative or endodontic treatment, maybe extraction be better if the patient wants or need orthodontic treatment and we can extract this tooth. So in general, before we start any thing, we can think about orthodontic diagnosis, consultation for the best of the patient. Yes, we can. There is a lot of common culture also wrong that all patients not suitable for orthodontic, and this is wrong. We can do orthodontic treatment even for 60, 70 years old. It will be not comprehensive treatment. It will be not helping the patient to solve only answer, but it will be very much better together with other specialists. We have Invisalign. All of you know about it. So if the patient don't want treatment because of the braces, also we have the answer. We can do it without braces with Invisalign, and Invisalign now very much improved than 10 or 20 years ago. Some doctors, experienced doctors, of course, even do surgery cases with Invisalign, not me, but in general. Sometimes the patient don't want the orthodontic because it's taking time. As I said before, all this treatment is adjunctive treatment, less than 1 year, maybe 6 months only. But for example, it's a complicated case and the patient in hurry. There is ways with assistance of surgery like this way, decortication of the bone. It looks a little bit scary, but we can encourage our patient to try it, and it will make the orthodontic time half, and the stable and result will be much more better. Even if it's very speed, it's very stable.
By what?
We can do these holes to the bone and then put the bone graft and cover. And this will make the orthodontic movement much more faster.
What's the mechanism? How it will work?
Because, there is Dr. Ferguson and orthodontic and Dr. Wilco, periodontitis, maybe more than 100 studies about this, about chemical, وسائط كيميائية, proteins. And it's all about fastening the inflammation process that need to move the teeth. After all of that, maybe tomorrow all of you calling me for every patient, so there is some restriction also. Don't call please if just for prestige. We are a big hospital, we have all the specialists. Let me call the ortho for you, the surgeon for you, all the specialists for you. Don't call if the patient don't care. And you ask him, orthodontics will give you better solution. But if he don't, I don't want, okay, don't call me to convince him. Because we don't want to force treatment on the patient. We offer the treatment. If he is interested, we can go to the next step. With the severe periodontics problems, also it's contraindication, especially in this country. And finally, the babies less than 6 years old, we didn't start any treatment, whatever the case. Unless it's a cleft palate, for example, or some syndrome, and also this case we will not work here. Yani. Even in USA, they don't work in general hospitals and in small centers, cases like this. There's specialist center for these cases. So don't call me, please. Finally, this lecture is not about transferring patients. To me, it's not about making more money to the hospital by putting the patient for over-treatment, and not about the patient either, because a lot of patients don't deserve, maybe in some point of view, to give them all this care we are talking about. But this lecture is about each and every one of you going home every night, put your heads on your pillows and feel proud and self-respect about your work to be a professional and good doctors. Finally, I would like to thank Dr. Mazen Ghanem, the head of department, to allow me to introduce this lecture. He's our senior, and Dr. Fuad Malki to the organization committee. And Dr. Luay Younes, I hope he will be here for giving me this smile this morning, and I hope all of you give smile to your patients. And thank you for attending, and have a good dinner.
شكرا دكتور علاء. أول شيء إذا في حدا ما سجل اسمه رجاء اللوحة هو بس يسجل اسمه هو الطالب. Today is sponsored by Lakalut. وين تبع Lakalut؟ They're gonna give us a small presentation about Lakalut, and then they have a